symposium is yours. Yeah, so how can I say, benvenuti. This is going to be probably the only word in Italian I can say. I said to yesterday evening after a wonderful dinner that the only possibility for me to say something in Italian is after a shot of grappa. So, because I didn't have, I'm not going to speak in Italian. So I would like to thank very much Dr. Gazzano, and also that I think this is the first time that we meet together. And I would like also to thank you very much, Guido. Guido, we are not going to say how many years we know each other because we are still very young. Yeah. So I'm going to talk about the Paris system, and yes, as Guido said, I'm going to also give you not only the update of the Paris system, what we call the Paris system 2.0, but also the needs for going further, what we could call the Paris system 3.0. And so, as Guido said, it started in Paris, and why do you started to work on that? Because there were some pathologists who were saying, I hate urines. But more important is that the range of atypia was extremely variable from one institution to another one. It was, as you say, ranging from 2 to more than 50%. So it means that if you, in 50% of the case, you say to a clinician, this is atypical, urine cytology is for sure unuseful. But behind that, there was a wide observer variability. There was no reproducibility. So it was a catastrophe. And we can understand that the clinician and the urologists were thinking that we don't care about urine cytology. So we decided to change the way by trying to do something new. So we start in 2013. We put the major cytopathologists dealing with urine cytology all together in one room, and then I said to them, we are not going to go outside from that room until we find a way to work on a new classification system. And so they said, yes. After 2 hours, we decided to start the project. But of course, the project was a very long way because we wanted to make it by consensus. You know, not to impose things, but to associate a lot of people within the project, to be inclusive enough, to associate also a pure histopathologist as well as clinicians and urologists, in order not to do a new classification of cytology, but to do something which would benefit at the end for taking care of the patients. And I don't remember where, but I think that you can probably see somebody. Guido is somewhere here. So the one who is going to find him is going to win the award of the day. And so it included almost 50 people, and 20 from the States, 21 from outside from the States, and from 5 countries. And the main idea was to ask the following question: what is important in urine cytology? This has been the main question and the main illustration of the book published in 2016. So it means 3 years of work altogether. The basis for the update that we are going to see today is that we recognize a deficiency, we update the literature, but remember that the first, the Paris system 1.0 was based on retrospective studies. And the TPS, the Paris system 2.0, is more concentrated on prospective studies, and mainly prospective multi-center studies, which is more robust in terms of evidence medicine. And so we went to the second book, which was published one month ago or 2 months ago, 2022. So I was telling you that the question that we asked in the first classification was to detect high grade. And why to detect high grade? It's because high grade represents the type of lesion which is going potentially to be extremely detrimental to the patient. And of course, we are not talking about the fact that it may be muscle or not muscle invasive, but to detect the presence of high-grade cells. And at least this new paradigm is exactly the same in the Paris system 2.0. So we didn't change our mind, and because we found that this was really checking with what the clinician and the urologist wanted to detect something which is going to be detrimental for the patient. We can talk later about low-grade lesion, but in fact, this is not the question that the Paris system asked first. And this may be one of the questions that the Paris system 3.0, the next one, will ask. And so it means that all of you can contribute to the Paris system 3.0 by working based on the principle of the Paris system to see how we could handle to be better to detect low grade. But again, remember, the question that we are asking now is how we can detect the high grade. So if we want to detect the high grade, it means that we have to know what is not a high grade, what is a negative for high grade. And this is where the problem lies. because saying that it is not high grade means that you have to know the different pictures of things which may mimic a high grade. And this is where the difficulty, the challenge is for the histopathologist or the pathologist in general doing or not cytopathology. So let's look at, and I'm not going in details, but this is extracted from the book, the pathogenesis of urothelial carcinoma. What we see is there are probably a kind of sequence, but this is more complex than what we thought at the beginning. What is what is important now from the atlas, which was published in Nature in 2014, is that these different type of lesions are defined not only by morphology, but they have also a molecular profile. And this molecular profile may be for sure be assessed using the material that you get from urine cytology. So what does it mean? It means that probably not today, but in the following years, we will be able to define things which are not high grade, maybe low grade, by combining morphology and molecular tools. And we all know that the material that you get by cytology is extremely useful for applying molecular tools. And the main reason is that the sample that you get is non-invasive and also fresh. So again, the paradigm is to know we don't care, we are not asking the question, are we able to detect the low grade, because we already know that we are not good at that. Question is to know what is important for the pathology. So I'm not going to much in detail about this procedure, but this is the algorithm which is suggested. And very close to the algorithm was suggested already in the first Paris system. And it means that if you see something which is abnormal, atypical, suspicious, or malignant, even if the sample is not adequate, then it means something. What was said in the Paris system 1.0 is that we should have at least 30 milliliters. And so it is probably the only thing which has been confirmed in the Paris system 2.0. Because about cellularity, it is difficult. It is difficult because we still don't have a lot of series, prospective series, being able to count the number of cells that we have in a specimen. So again, I think that in the future, for the Paris system 3.0, we will need your input to make things so that we are able to define what is the level of cellularity which may be a threshold for considering that the sample is adequate or not. The Paris system 2.0 include, for negative for high grade, include a clarification and streamlined discussion of atypical versus benign appearing urothelial tissue fragments, and also a first approach, like a discussion about low-grade urothelial neoplasm. Because if you remember what a low-grade lesion represents for a cytopathologist and what a low-grade lesion represents for a histopathologist, they are not saying the same thing. Because in histopathology, low-grade lesion consisted of a spectrum of different lesions with different morphology. And in front of that, you have one term for low-grade in cytology, which is mainly something which looks like a papilloma. And so this is why in the first edition and the second edition, we just say, if you see a core within your cytology specimen, you see a core, a real core, not a pseudo one, but a real core, with vessels, conjunctive, and around you see epithelial cells, urothelial cells, then you can suggest for sure that there is a low grade. But there are probably a lot of other aspects than just the fact that you see a papillary structure that represents a low-grade lesion. So the other thing which is extremely, I think, important is that we define, the group try to define characterization of what we call the degenerative changes in benign specimen, because some of these degenerative changes may again mimic high-grade lesion. We confirmed the fact that the performance of the negative for high-grade was really a useful categorization. And in the book, which is now a little bit thick, you will find much more illustration. So the definition is for negative for high grade is a sample of urine, either voided or instrumented. And remember that when you say instrumented means that there is an impact on the cellularity. And so this is why I think that in the next edition, we will have, and they are already work on that, trying to define what is a high cellularity or what is the minimum cellularity for instrumented type of approaches, including washing system. For sure, the sample has to be adequate, as we said from the beginning. It lacks any cytomorphological findings shown to be significant and may include, look at that, a large series of sub-entities, which are the entities that may be diagnosed by histopathology, and that they are not always mirrored in cytopathology. So then the question is to know what is normal. And we know that a lot of things which are considered as normal or negative for high grade are maybe sometimes difficult to, maybe very challenging. So the challenge of the cytopathologist or the person who is dealing with cytomorphology is to have in mind the different aspects of cells which are exfoliated within the bladder or through the ureter, and to identify them not as atypical or high grade, but within the limits of the normality. And so these are examples in which you see, for example, umbrella. Remember that they were kind of false positive at the beginning when in situ hybridization started, because they were identify cells with an abnormal DNA content by fish, but then they realized that they were only umbrella cells that we already know may have not only one, but sometimes double or multiple nuclei. So, and the reactive umbrella cells are one of the challenge of the cytopathologist, mainly when the cytopathologist is in the learning curve and didn't have to face with some of these aspects, which may go from multinucleation, very large cells, or very hyperchromatic nuclei, or a mix of umbrella cells and acute inflammation. So, but now, again, what is important is to not to say in front of this type of pictures that I don't know what it is, but to range them in the category of non-high grade. These are other pictures. You have kind of, for example, squamous dysplasia that we know may arrive relatively frequently in a bladder, and which are not, they are within the limit of normality. So they, of course, you have to differentiate that from something which is an epidermoid carcinoma coming from outside from the bladder. But when you look at this type of image, there is or mucinous, or the other picture that you have, for example, this one, in which for sure when you are starting to work in cytology, or when you never face such a problem and that you were not able to identify what is a seminal vesicle. So it means that then you can make at least something atypical and maybe high grade. The same for low grade. All these lesions should be put inside a kind of basket. But instead of having a big basket of atypical, then we have a big basket of negative for the question that we ask at the beginning, which is it a high grade, yes or no? There are also a lot of other pictures that you have to have in mind, and so which are the consequences of what the urologist did: brachytherapy, irradiation, the fact that the patient received chemotherapy. I mean, either not only local treatment, but also systemic chemotherapy and so on. So all these things that you have to be familiar with. Otherwise, the percentage of cases in which you are going to identify this specimen as as non-high grade is going to be too. Another aspect is the cytopathic effect of polyoma virus. I think that now a lot of people know what are the aspects, but you know, when we started to work on that and we did a survey, we saw that there was a lot of variability from one person to another one. And so, again, if we are moving from the negative or high grade to the atypical category, atypical urothelial cells, then again, the question is not to know exactly how we define atypia, because of course it's different. It may be different from me, may be different from Dr. Gazzano, it may be different from Dr. Fada, but what we try to do is to identify what is not an atypia. So instead of trying to find the positive aspect, we are trying to see the mirror of that, what is not. And so these are some examples that were illustrated already in 2015, so means after the first, after the Paris System 1.0 by Eva Wojcik, who is one of the leader of the group. And I would really suggest, beside the book, it would really suggest you to look at this the paper from the Journal of American Society of Psychopathology published in 2015, illustrating some of the aspects, and of course the polyoma, the polyoma virus was in the middle. Okay, but you see also already here the low grade, or what may be suggested that at the low grade. Now we put this pseudopapillary or papillary lesion in the box of negative or high grade. So, of course, what I said is that what is atypia? Nobody knows what is atypia. So it is something which is in between. I know that it is negative or high grade, and I'm worried about, but I'm not sure that it is malignant. Okay? So, of course, in between is always something very vague. And this is also one of the challenge for the Paris System 2.0 to try to reduce drastically the percentage of atypia. Because just imagine that you have an hematuria, you go to the urologist, you have a urine sample, and the urologist say to you, this is atypical. What do you think? Of course, you will say, what do you mean by atypical? But because you are cytopathologist, you say, oh my God, it may be very close to high grade, it may be very close to, so I would like to know. So the less the number of atypical is, and the best is for the patient. So it was one of the goals of the Paris System, and it worked. It worked because at the end, if I have enough time, I will show you what was the percentage of cases which were considered as atypical before the Paris System, and after the implementation of the Paris System, it decreased dramatically. So the goal was, we put the target was achieved. But of course, there is no diagnostic test which is black and white. There is always something which is in between, because it depends on the threshold. And you can see that for biochemical tests, depending on the machine where the sample is processed, you may have a threshold with a kind of standard deviation, which is linked to the type of processing. And so this is the same for us, is that, of course, we would like to have a black and white situation where we can say there is no disease, and here for sure there is a disease, but in fact there is something in between, and this is the limitation of our brain for sure, or this is a limitation of the collective experience. So within the updates of the Paris system, we had much more discussion about the cytomorphologic criteria, because we were based our discussion on the fact that we saw the result, the positive result of the implementation of the Paris system 1.0. We also addressed the question about what are the morphologic appearance in different cytopreparatory techniques, because I don't know what you use, but there are people who are using, what should I say, the system of the people who are in the back of this room. There are people who are using cyto sanctification. There are people who are using other type of devices, Becton Dickinson, Hologic, and so on and so on. And so we are talking about pictures, but the pictures are, the consequences of the entire processing, including the system that you use to visualize the lesion. And so this is probably something that we will also have to ask in the next update of the Paris system. Yeah. So the atypical, in fact, are defined by a major criteria, which is nuclear to cytoplasmic ratio more than or equal to 0.5. And we all know that our capacity of evaluating the ratio of two surfaces is not so good. We know that. And I will show you at the end something which is, I think, interesting. Because then here, digital cytology will be probably extremely interesting as a tool for helping you to decide, is it really more or equal to 0.5? And then one of the following criteria, which are hypochomesia, irregular lumpy chromatin, irregular nuclear contours, which are basically aspects that every cytopathologist deal with. But we will see also that within the Paris system 2.0, we'll see that hypochomesia, which is usually something that is extremely useful for the cytopathology in general, maybe also in very rare case, not a good aspect, because we know that there are high-grade lesions which are hypochromatic. But this is still something that we can So here are some examples which are taken from the book, and you see they are the cluster of relatively deep cells which are normal, and something in which you see that the high nuclear to cytoplasmic ratio is some of the cells, they have something which is around 0.5 and hyperchromatic. So you have the major criteria and one, at least one, and the hypochomesia is so pronounced that it is difficult to evaluate, of course, the clumpy chromatin or the clumpy chromatin by itself. So other aspects which may be a little bit more puzzling for people, because you see that there are some nuclei which are bigger, and you could say that there are some anisonucleosis, but the hypochomesia is not there. At least the largest nuclei are not hyperchromatic. And so this is still something in which you have the nuclear to cytoplasmic ratio, which is around 0.5, but you miss the hyperchomesia, and you don't have the clumpy chromatin. Other aspects, and so for example on the right side, and these are two pictures from the same specimen. So on the left side it's okay, but on the right side, of course, you are a little bit worried about. But what you have to see is that the cytoplasm of the cells are micro or macro vacuolated, means that these are degenerated cells. So your diagnosis will be based on the left side of the picture. The same here. Then we'll see that the gray zone, which is mainly atypical cells, and some of the suspicious for high grade, we'll see that it is also based on the number of cells that you see. Okay? So for example, here, you have one cell with a hyperchromatic nuclei with a nuclear to cytoplasmic ratio, which is for sure higher than 0.5. And, but then the question is to know, are you able to make the diagnosis of high grade on one cell? And the answer is no. So you need to have enough cells like that to say suspicious for high grade. And then we are going back to the fact that the cellularity is going to be extremely important. And so I think in the future, we will probably have also to count the cells. I'm not going to say that we will have to count it on the Malassez cell, but we will have to have devices which are able to count the cells. How many people are counting the cells in the urine specimen among you? No, nobody. At least I don't. Okay? So this is very subjective. So we'll have probably to ask the people who are selling devices to help us to identify the cellularity of the specimen. So the update for suspicious for high grade is an updated discussion on the risk of high grade, because remember that the beauty of the Paris system is not only to give diagnostic categories, but in front of that to say what is the risk within this category, and we are going back to the patient. So the patient knows by reading the report and the conclusion of the report, the people may know what is the risk of having a high grade. So in the Paris System 1.0, it was based on retrospective studies, and so we know that there is a bias. But on the Paris System 2.0 now, it is based on more prospective studies, so it means that the risk, which is defined, is a data which is much more robust than the previous. So what is nice is to see that the numbers didn't change a lot. So it means that at least within the community of morphologists, there is this possibility of identify the major aspects. So what are the criteria for suspicious? So again, the major criteria is the fact that the nuclear to cytoplasmic ratio is at least 0.7. And here we enter in a kind of difficulty, because are we sure that we are able to always identify what is more than 0.7 or less than 0.7? So this is a problem, because again, there is a lot of variability from one person to another one to identify the nuclear to cytoplasmic ratio. And at least with this major criteria, one of the following, which is, and you see that there is not the hypochomesia, but moderate to severe hypochomesia, irregular clumpy, or irregular nuclear membrane, because we know that there are some high-grade lesions which are hypochromatic. And so these are some aspects that you can probably, depending on the number of cells, and the people say, okay, is it 5 cells? Is it 10, less than 10 cells? So still a matter of debate. And I wouldn't push you to put that in the category of suspicious for high grade or atypical, because if you find these, there are 6 cells which are abnormal. If you say atypical, it would be okay for me. And if you are more experienced and you are very sure that it's these 5 cells are highly abnormal, then you can say suspicious. But would you say that it is high grade? This is the question here. I think that we don't have enough aspect to say high grade. So in summary, you have the negative in the lower part left, and then the suspicious in the upper right picture, and then in the middle something which is a kind of gray zone subjected to a lot of discussion between us. So for positive for high grade, I wouldn't say that it is very difficult, because the diagnosis is usually very easy. It's a 5-second diagnosis, because most of the cells are abnormal. Most of the cells, they have a very high nuclear to cytoplasmic ratio, and they have at least one or two of the minor criteria. So the updates were, and this was also a good news from the Paris System 1.0, is the criteria for high grade were accepted worldwide. But what we realize that the spectrum within high grade, the spectrum of nuclear to cytoplasmic ratio may be changing from one aspect to another one. It means that you may have cells with a nuclear to cytoplasmic ratio of 0.5 or less than 0.5 within a high-grade lesion. But you always find the number of cells with the nuclear to cytoplasmic ratio, which is extremely abnormal. So it means that, again, the nuclear to cytoplasmic ratio is relative. This is a major argument. This is a major argument, but there are some variation within the bar. And the second thing is the hypochomesia that we, Dr. McIntyre from Loyola University identified. But this is less than 10%, and probably less than 10, maybe 5%. Again, here, you have the same problem than for the atypical. Don't identify something which is degenerative as something which is suspicious for high grade. So stick to the definition of the high grade. And there are a series now of high grade subtypes that you can suggest by cytology. I think that I have a picture of that. The last one is that now we are addressing the question, what is the significance of fibrovascular cores in high grade? So this is a question that we ask for the next updates, and we don't have an answer right now. So the criteria for high grade is in between at least 5 to 10 cells, with a nuclear to cytoplasmic ratio more than 0.7, and we will see again what is that it is sometimes difficult to identify 0.7, a moderate to severe hypochomesia to take into account the hypochometic possibility, irregular membrane course or clump chromatin. So 5-second diagnosis of high grade. Most of the cells, they are extremely abnormal, and the nuclear to cytoplasmic ratio of more than 10 of them are elevated, more than 0.7. Of course, there are some cells which looks like the others with a nuclear to cytoplasmic ratio of 0.5, but it means that they are they may be also high grade, but these are not the cells that we are taking into account to make the definitive diagnosis. So you will see a lot of pictures of that, but remember that you may have these high-grade cells which are dispersed, as in the upper part of the picture, or aggregated, and like in the lower part of the picture, where it's a little bit difficult because these cells are so close that it is a little bit difficult to evaluate the nuclear to cytoplasmic ratio that you should evaluate on the edge of the clump. So there are also a description of additional cytomorphologic features that I'm not going to illustrate, and also some variants. I already mentioned the fact that there may be something in between 0.5 to 0.7, and some of the variants which are listed as squamous or glandular differentiation, micropapillary or plasmacytoid. So the highlights is the incorporation of the Cancer Genome Atlas, molecular characterization, and update performance data for each diagnostic category, more discussion on the degenerative aspects, which I think are really some of the things that we are challenging every day as cytopathologists. The integration of low grade in the non-high grade category. Remember that our goal is to identify high grade, and some revised cytomorphology criteria for the for the two categories of the gray zone, as well as the category of high grade. There is then a chapter on the upper urinary tract, and I think that it's going to be a major addition in the Paris System 3.0, because again, we don't know what is the level, what is the threshold for cellularity in the upper urinary tract. We don't know, and this is based on the experience of the Paris System. We cannot decide, but for sure, you need to have at least 10, maybe a little bit more than 10 really abnormal cells to make the diagnosis of high grade. If you are dealing with a sample coming from the ureter, instead of having 5 to 10 high grade cells for making a diagnosis of a bladder, this is different. There is an additional, as I told you, something about cytopalpatory techniques. Also, there is not only the risk. You will see that there is an evaluation based on prospective series about the risk of high-grade malignancy, what they call ROM, and then the new chapter on the history of urine cytology. So the Paris System didn't eliminate the gray zone, because atypical and suspicious still exist, but at least the Paris System defined it. And the Paris System 2.0 is not saying that we eliminate the gray zone. The gray zone is still present, but the percentage of this gray zone is decreasing, which is extremely important for if you are thinking about the consequence and the patient. And this is what is illustrated in there. So just to show you, and this is, I'm not going to comment on that, but you see here that before the Paris System and after the Paris System, the amount of atypia significantly decreased. There is also an algorithm to help you to find a way to identify the lesion, and of course, the nuclear to cytoplasmic ratio is just the beginning, and then you will see that there is a difference between the instrumented and the non-instrumented urine cytology, and then there is that, which is a graphic illustration of some visual differences, and if you do the blind test, it's very interesting. Try to take one picture and to evaluate what do you think is the nuclear to cytoplasmic ratio. It's worrying because, of course, 0.3 and 0.8, it's okay, but our own gray zone is between 0.3 and 0.8. And so this is where I think that digital cytology is going to help us a lot, for sure. Because instead of having a qualitative evaluation, we will have a quantitative evaluation, which is more or less variable, and also an evaluation of the hypochomesia by technique. And then for finishing, I think that I'm a little bit late. For finishing, in front of each category: unsatisfactory, negative for high grade, atypical urothelial cells, suspicious for high grade, and high grade, you have the diagnostic criteria, an example, and much more important, the frequency, as well as the risk of malignancy, which means that the frequency is going to be something which may help you to monitor the lab or your own activity. Because if you have a percentage of atypical samples of 30% in your lab, it means that there is probably either something which is regional, but I don't think so if we are dealing with the large numbers, or there is a problem of one of the people who is working with you. And the last column, which is the risk of malignancy, is something that we should be able to discuss with the patient, that the patient should know. Because we are not God. Medicine is not God. So the patient, they have also to accept that we are living in a world in which we always evaluate the risk of crossing the street or not crossing the street. This is exactly the same thing in medicine, because no diagnostic test is 100% black and white. And finally, I would like to dedicate this presentation to one of my very good friends, Stefan Pambuchian, who was originally from Romania. He went to the States and he worked at the Loyola University. He was a wonderful person, but unfortunately working on the TPS, on the Paris System 2.0, then one of sudden he died in 5 seconds, by a heart attack, probably a major one. And so I was one of his friends, and it is an honor for me to also to dedicate this presentation to him. And so with that, I think that I would like also to thank Gulis and Eva, as well as Dottie and Dan, and to say thank you very much.